required like prompt treatment and prompt recognition to prevent mortalities. And those syndromes like sepsis, meningitis, encephalitis, septic arthritis, osteomyelitis, and we'll talk about orbital periorbital cellulitis. So let's talk about sepsis. So before talk about sepsis, we need to understand certain terminologies. What is SARS? What is infection? What is bacteremia? What is sepsis? What is septic shock? So anyone had a clue what is systemic inflammatory response is? Yes, so it's a collection of criteria. It's like a syndrome. It's not specific to infection. It can happen with any inflammation. So it's presence of two or more of like high or low white blood cells, like abnormal white blood cells, or more than 10% of immature white blood cells, or high or low temperature, or low blood pressure, and a presence of tachypnea. And when we mentioned tachycardia or high heart rate, it's important to notice it's in the absence of any external stimuli. So that is the systemic inflammatory response. What is infection? What is bacteremia?
Infection is the active multiplication of an pathogen.
Active multiplication of pathogens, and
that does not mean the presence of a disease.
That's more of bacteremia, or like bacteremia. It's presence of viable organisms, and those organisms can replicate. But sometimes it doesn't require, doesn't elicit any symptoms in the host. Sometimes you have bacteremia from inappropriate blood collection. So you have like coagulase negative staph colonization, and that we will have you have positive blood cultures, but the host doesn't have any symptoms. So what's induced symptoms in a host? What is infection? There will be a tissue invasion. So that's what elicits the inflammatory response and the symptoms in the host. So infection, like tissue invasion by the microorganism. Bacteremia is just the presence of viable organisms in the blood. And what is sepsis and septic shock? So sepsis, it is systemic inflammatory response plus suspected or proven infection. Septic shock, presence with end organ damage, and specifically cardiovascular damage. And the cascade will start usually, we mentioned all those. The cascade started from the beginning by presence of endotoxin or exotoxin, lipopolysaccharide, or presence of the bacteria itself. And usually the triggers of all the problems started by macrophage. Macrophage will release tumor-necrotic factors, and more tumor-necrotic factors will release more cytokines, and you'll have a lot of cytokines. They call it cytokine storm. Then those cytokines can trigger hypothalamus for fever, tachycardia, tachypnea. They will go to vessels wall and cause vasodilation. They will go to capillary endothelial cells. They make more platelet adherence and neutrophil migration, which cause all the symptoms of thrombosis versus hemorrhage, and ended up by tissue damage and death. So we need to start that, when you see all the sepsis guideline, antibiotic should be started, and there is a golden hour and there is golden minute. So antibiotic should be started as soon as possible to prevent those cascades. And sometimes, even if antibiotic is started, when this cascade is triggered, sometimes antibiotic cannot stop the cytokine, and patient can progressive with a severe sepsis and shock, and sometimes death. So what is the in neonatal period? I think you took it in a neonatal infection or no? Early onset, late onset, late onset. Not yet. So it's important in neonatal period to distinguish between early onset and late onset sepsis. Why is that? Because anyone know why? It's present in the table.
Maybe different organisms.
Yes, because of different organisms. So early onset, it's the all box they agreed early onset is done 72 hours of life. And what is the most common organism of early onset neonatal sepsis usually?
Rubella.
Rubella. No, rubella is causing what? Rubella, it will not cause sepsis, it will cause congenital infections. So there is difference between congenital infections and postpartum infection. Exactly. So all the organisms of early onset sepsis are related to maternal genetic tract. It's the delivery way. So group B strep, also what else? Gram-negative organisms and Listeria. So we need to memorize those organisms by heart. So all those organisms will cause sepsis and meningitis or whatever in early onset. Late onset, and we have late onset, but usually some they will differentiate between late and late onset, some they will put them as one category. After that, we'll start about talking about some nosocomial infection. So we'll talk about staph aureus, coagulase negative staph. So we need to cover those organisms. But early onset, we need to cover only certain organisms, which is group B streptococcus, gram-negative like E. coli, Klebsiella, and Listeria. And usually in neonatal period, it's like the clinical presentation, sometimes it's non-specific, or the patient can have a certain focal infection. But in early onset, it's unlikely to have focal infections like osteomyelitis or whatever, or meningitis. It's more common in late and late onset sepsis. So we mentioned the organism for early onset neonatal sepsis. It's group B streptococcus. And you need to know, just sometimes in the exam, they will mention to you not group B streptococcus, they mentioned the gram stain will show gram-positive cocci, the gram stain will show gram-negative bacilli. So we need to know each one of them, what's their group. I think you took that in microbiology, but to recap, usually group B strep is what? Gram-positive cocci, gram-negative organism, E. coli, Klebsiella, they are gram-negative bacilli. Listeria is gram-positive bacilli. So Listeria is uncommon. Although it's not common, we need to still cover it because it's not covered with the usual empiric coverage for early onset sepsis, which is sometimes we start gentamicin, and if the patient had meningitis picture, we start cefotaxime because gentamicin will not cross blood-brain barrier. Listeria, we need to add ampicillin to cover Listeria. Late onset neonatal sepsis, as I told you, there will be factors of hospital-acquired infection. So we will go to coagulase negative staph and staph aureus, and we need to change our coverage based on that. What about patients between 1 to 3 months of age? Still, you have the neonatal organisms, plus strep pneumo, Neisseria meningitis, Haemophilus influenza, especially type B. So again, you need to know all the details about the organisms. What is their microbiology? What's their appearance in gram stain? So strep pneumo is gram-positive cocci, Neisseria is gram-negative tubercocci, Haemophilus influenza gram-negative coccobacilli. So although we have high coverage vaccine rate, and we mentioned that in the previous lecture, still we see cases of strep pneumo. And why is that? Anyone recall why is that? We mentioned that.
Because of the stereotypes.
Yes, because there is a lot of serotypes not covered by vaccine. What about Haemophilus influenza B? It's really uncommon with the vaccination unless the patient is unvaccinated and in community with a low vaccine rate. But like during my practice, I saw maybe only 2 cases of Haemophilus influenza type B. More than 3 months of age, it's strep pneumo, Neisseria, and Haemophilus influenza type B. So what's the usual manifestation or clinical manifestation of sepsis, septic shock? So unspecific. Sometimes the patient will have fever, poor feeding, irritability. Some of the patients, they will have focal of infection, so they will present with meningitis, and we will come to that. And some patients, they will present with osteomyelitis plus sepsis. Some patients, they will have gastroenteritis plus sepsis, cellulitis. So it depending on the presence of focal infection, or sometimes it's unspecific symptoms. So by examination, usually you see all the signs we mentioned before, like fever, tachycardia, tachypnea, and some patients, they will have hypotension. And if the patient have Neisseria meningitis, they will have a specific rash. We call it meningococcal rash. And what is the characteristic of meningococcal rash? Anyone knows? So meningococcal rash, it's like very specific because it's usually non-blanchable rash. So you will apply pressure, the rash will not fade. So non-blanchable, and usually it's like purpuric rash. So presence of purpuric rash upon presentation of the patient with sepsis give us like a clue about the causative organism. So this is the purpuric rash, and no one will apply like if the patient is sick, no one will bring glass and apply the pressure. But usually how you distinguish the purpuric rash, when you apply pressure, it will not disappear. So it's indicative of meningococcal infection. So investigations, you usually what you will order. Okay. CBC, what will show you? Yeah, it can go in both ways, as we mentioned, like it can be high or low. White blood cells, what else other than white blood cells? Something need correction. If the patients have low platelet from the severe sepsis, they will need platelet transfusion. If the patient have low hemoglobin from like bleeding or from whatever, they will have packed RBC transfusion. Blood culture is the gold standard test to diagnose bacteremia and sepsis. And depending on the presentation of the patient, you will order, depending on the focal presentation, you will ask for urine culture, CSF cultures. If the patient less than 28 days, you need to ask for CSF cultures. But if not, and the patient presenting with a sign, symptom suggestive of meningitis, you will order it. If not, no need to order it. What about CRP, ESR, Brocal? So they are non-specific for infection, but if they are high, they give us a clue about the like serious inflammatory response. Or Brocal, the data extrapolated from adult population, it showed Brocal, like if it's like above 0.2, it's like giving you high certainty if there is a bacterial infection. So Brocal is more valuable test than CRP and ESR if it is present in your facility. And coagulation profile needed if like if the patient present with severe sepsis, septic shock, and as we mentioned in the cascade, there will be like problem with coagulation. So we need to ask for coagulation profile to correct the abnormality. So for management of sepsis, so we need to stabilize the patient. You need to start IV fluid. You need to start inotropes if the patient hemodynamic is unstable, and antibiotic as soon as possible, plus supportive care, plus management directed to focal infection if there is focal infection. So for empiric coverage for sepsis, it's not like, it depends on the resistant of organisms in your hospital. It's dependent on also resistant organism in your community. So the empiric coverage is changing, and it's also depending on the population. So as we mentioned in unit, usually ampicillin plus aminoglycoside. Some centers they have gentamicin, other centers they have amikacin. And patients between 1 to 3 months of age, we will add ampicillin plus cefotaxime because there is another organisms, as we mentioned before. And sometimes some centers they will add vancomycin if the patient is seriously ill. Above 3 months, you need to cover for strep pneumo, meningococcal staph aureus, Haemophilus influenzae, and usually the best coverage is 3rd generation cephalosporin, unless the patients have history of resistant organism, or if there is resistant organism in your like community, known in your community. If the patient's more than 48 hours of hospitalization, just you need to cover for hospital-acquired infection. And usually the hospital-acquired infection caused by staph aureus, MRSA, and Pseudomonas, so you need to cover for both. But for your level, no need to memorize like the empiric coverage for hospital-acquired infections or for a specific population like sickle cell disease. So just focus on the neonatal period and 1 to 3 and more than 3 months of age. So let's move to meningitis. Any questions about sepsis? Okay, so when we mention meningitis, so what's the meningitis? What does it mean? Where will be the infection?
And the covering layer of the brain, meninges.
Okay, so how many layers of the meninges we know? And if we mention meningitis, we like targeting which layer? How many layers of meninges? You are better than me for
3.
3 layers. So what they are? Exactly. So which one is have rich vascular supply, like network, we call it? Anyone recall?
Diameter. Durometer.
What's the remaining one?
Arachnoid.
Arachnoid. So arachnoid, from its name, so arachnoid, they have like rich vascular supplies and rich nerve ending. So meningitis is the infections of started where? So the organism will travel through blood-brain barrier and enter the brain through the arachnoid matter, the blood vessels in arachnoid matters. So the infection will start from arachnoid matters and can spread to the other layers and spread to subarachnoid space, and sometimes if there is complication will go to ventricular space and cause ventriculitis with meningitis. So that's clear. And you need to understand that because all like some signs, symptoms, all related to the irritations of the arachnoid space, irritation of the nerve ends, and the complication will start like neck stiffness. The positive signs for meningitis, which is Kernicks and Brudzinski sign, all related to the irritations of the meninges. Okay. So we mentioned that. So what's the pathogenesis? Where the organisms for meningitis, the commonest organism of meningitis for like healthy patients or immune competent host, let's say. Most of the organism will come from the nasopharynx. So they will cause mucosal invasion and they will penetrate bloodstream. They will enter through blood-brain barrier. Then they will generate inflammation within subarachnoid space. And that will like induced neural and auditory cell damage because of the nerve ending. So in meningitis, we need to prevent the infection starting from here before reaching to the nerve ending. So what's the etiology of meningitis? It could be bacterial, it could be viral, it could be others. So for viral, the commonest organism causing meningitis, and we mentioned it in the common viral illness, is enteroviruses. Adeno can present mumps, herpes also, but herpes is known to cause encephalitis rather than meningitis. For bacterial, it depends on the age, as we mentioned before. Other, it's at your level, it's no need to know the other infections, but TB can present, fungal can present, mycoplasma can present also with meningitis. So, okay, so let's talk about the common organisms. So in neonatal period, what is the commonest organism? It's the same as with sepsis, and you need to memorize it by heart. What is it? We just mentioned it.
Group B.
Group B strep and Listeria and
gram negative.
the gram-negative like E. coli, Klebsiella. 1 to 3 months, we mentioned neonatal sepsis plus the same organisms. And those organisms, they are the known colonizers on the nasopharynx. So what they are? The same organism with sepsis. Strep pneumo, Haemophilus influenza, and
Nigeria meningitis.
Neisseria meningitis. More than that, it's strep pneumo, Neisseria. Haemophilus is uncommon in patients more than 5 years of age. So we have entity called partially treated meningitis. Well, what is this entity? So patients, sometimes they have non-specific febrile illness. Sometimes the signs of meningitis will not be presented as early in the illness course. So patient, they will have maybe upper respiratory tract infection symptoms, and they went to the emergency room or to primary care clinic, and antibiotic will be given without any reason. Even if it will be oral antibiotic, and even with a single dose, that's enough to kill the bacteria. So patient, they will have progression in the symptoms, and they will come again to the hospital with the signs and symptoms of meningitis. But unfortunately, when you do the lumbar puncture and take the CSF culture, the CSF culture will be negative. And you will be in dilemma for this patient. The patient presented with signs and symptoms of meningitis, but you don't have any proof of that. This time, the PCR and rapid antigen will help you, but sometimes they are not covering all the organisms, but they will cover the most common organism. Rapid antigen, it's not used now anymore. It detects the bacterial cell wall. Now we use more of PCR tests. And sometimes the patient have still some signs on the lumbar puncture of CSF infection. So the first thing will disappear with antibiotic is the culture. So culture will be negative. After that, the protein will be neutralized. Then the glucose, and the last thing will be the white blood cell. So sometimes the patient will have high white blood cells in the CSF, and they will have low glucose, normal protein, and negative culture. And if you are lucky enough, you will have positive PCR. Most of those patients, they will receive the longest course of antibiotic with empiric antibiotic for 2 weeks, just because we don't know what's the organism. So take home message, don't start antibiotic unless you know what you are treating. So we mentioned the commonest organism. Clinical manifestations of meningitis. So by history, the patient will have, if the patient verbal and old enough, they will have like headache, photophobia, but the usual signs and symptoms usually fever, poor feeding, vomiting, irritability. Some patients, they will have abnormal movement. Some patients will have loss of consciousness. By examination, you might have fever. Upon presentation, you might have purpuric rash, as we mentioned with meningococcal. Sometimes patient will have neck stiffness, and they will have positive proximity and kerning sign. So what's the theory behind neck stiffness and proximity and kerning sign? So it's, as we mentioned, it's all related to the irritations of arachnoid meninges and subarachnoid space, and irritation of the nerve ending. And some patients, some certain age group, they don't have, like, you will not find like positive neck stiffness or positive kerning and proximity sign. Anyone know what's the limit and why is that? So for the patient less than 15 month old, do you think they will have neck stiffness and positive proximity and kerning sign? Any thoughts?
I think yes,
Yes, okay. And why is that?
because closure of the fontanelles.
So did they have open or closed anterior fontanelle?
Anterior closure around between 1 year to 18 months.
Okay, so for the patient less than that, they will have open anterior fontanelle. So the opening of anterior fontanelle, they give them more space to spread like the infection. So the symptoms and signs will be less. So they will not present with neck stiffness or positive proximity and kerning sign. Okay, is that clear? Some patients, they will have focal neurological signs. Some patients, they have papilledema upon examination. Okay. So what is kerning sign and proximity sign? At your level, you need to like know them and memorize them, but usually in practice, we are not doing them anymore. And I'm sure you like took those in medicine. So kerning started by key. So for me, like it's the same as the knee. So that's how I memorized them. So what's kerning sign? When the hip flex and the knee flex, the extension of the knee will cause the patient, they have like irritation in the nerve ending and cause pain on that. Okay. Proximity sign, when the patient is lying supine, when you lift their neck, there will be involuntary movement just to avoid the pain of they flex their knee. Okay. Clear? Okay. So I took those investigations from your book, but we'll go through them one by one. So CBC, as we mentioned with sepsis, we need to do it. Blood glucose and blood gas. It's important to take blood glucose for two reasons. to check acidosis and the septic shock and the end stage, but also we need sometimes the best measurement to measure the CSF glucose is to compare it with the serum glucose. So if you need to know, is this a really low glucose in CSF, you need to compare it to the serum glucose. Coagulation, as we mentioned, urea electrolyte, liver function tests, as needed. Urea electrolyte, sometimes you need it to assess the electrolyte, and if there is some electrolyte imbalance. You need to take culture of blood. Sometimes the patient meningitis secondary to bacteremia, and urine, stool, those are depending on the focus of infection. Rapid antigen test, as I told you, now it's not anymore requested, but the most important is PCR. And PCR, we need to do it on CSF sample, and sometimes we need to take nasopharyngeal aspirate and do PCR on it, or sometimes from the stool, because as we mentioned, some causes of meningitis are secondary to viral, and most common viruses are enteroviruses. And if you found enteroviruses in the nose and the stool, and you see the CSF parameters with low glucose, high protein, high white blood cells, but mainly lymphocytes, that's indicative of viral meningitis. Lumbar punctures, and you need to send it for, usually we will send lumbar punctures for what? What is the analysis in CSF we will do? Okay.
And the appearance?
The appearance is important too. And we send it also for cultures, gram stains and culture, and PCR if needed. So you will send a lumbar puncture for CSF analysis unless contraindicated. When it's contraindicated? Which situation? With increased intracranial pressure, and if the patients have thrombocytopenia, have coagulation problem, if the patient hemodynamically unstable, if the patient have focal neurological signs and symptoms, all those are contraindication for lumbar puncture. PCR of blood and CSF, usually we are not doing PCR of blood, we are doing PCR of CSF. PCR of blood, even in big centers, it's not available. And others, if suspect like TB, will send all the TB workup. And CT, neuroimaging and EEG as indicated. So neuroimaging, we will not order neuroimaging unless the patient have focal neurological signs and symptoms, or patients not improving on the empiric coverage of meningitis. So we mentioned what's the contraindication for lumbar puncture, and how you position the lumbar puncture, in which position you will do your lumbar puncture. Between L3, L4, L4, L5, and why is that? So the spinal cord will end where? Usually the spinal cord will end at L2, and you will do your, you'll take your samples between L3 and 4 or L5 or 4, L5. And the best positions for pediatric is prone position, and with the knee and hip flex, and with you can palpate the iliac crest. It will be your marker for the positions between L3 or L4 or L4 and L5. And you can correlate that with the intervertebral space. Okay. So this it'll be done on older, I think more, it will be more than 12 years. Sitting positions also is one of the positions for LP, but in pediatric we prefer the prone position. So what's the typical changes in CSF meningitis or encephalitis? So at your level, you just need to know what's the normal, and what is the abnormality if it is like increase or decrease. But you don't need to memorize like certain levels. It will be like in the exam. Sometimes we will provide it to you. Just you need to know what's the meaning of when it will be high and when it will be low. So normal, the appearance will be clear, and white blood cells usually present upon 5. Normal protein, it's up to 0.5, and in neonate up to 1, we have normal protein. A glucose, if you measure the blood, it's more than 40% of serum to CSF ratio. That's normal. Bacteria, sometimes it will be turbid, the appearance, and white blood cells mainly polymorph. It will be high. The protein will be high, the glucose will be low. For viral illness, the appearance will be clear. White blood cell will be high, mainly lymphocyte, but initially it will be polymorphs. And the protein will be normal to high, glucose will be normal to low. With TB, it's like with bacteria, but everything will be exaggerated, and white blood cell is mainly lymphocyte. Encephalitis, you might have normal protein, normal glucose, normal white blood cells, but sometimes it will be elevated. For partially, I bring the other pictures just to know the partially treated meningitis, as we mentioned before. So for partially treated meningitis, you will have what we mentioned before. What the abnormality you will see in the CSF analysis with partially treated meningitis. So what do you think about white blood cell? What is the first parameter will be corrected with partially treated meningitis?
Culture.
So the first parameter is the culture. So the culture will be negative. White blood cell, still you have some high white blood cell. Protein, normal to high. Glucose, normal to low. So the first parameter will be corrected. Grams 10 and culture, then the protein, then the glucose, then you have the white blood cell. No need to memorize all those numbers and details. So what's the your empiric coverage? It depends on the age, and so for each age group, we'll have like different coverage. So as we mentioned, for neonates, the most common is group B streptococcal, gram-negative like E. coli and Klebsiella and Listeria. So what is our empiric coverage will be? Ampicillin and cefotaxime. And in sepsis, we mentioned it is ampicillin plus aminoglycoside, but in meningitis, aminoglycoside, they are not crossing the blood-brain barrier. That's why we replaced them with cefotaxime. And why cefotaxime, not ceftriaxone? They are third-generation cephalosporin. Yeah, what will happen with excretion? That will develop the neonates, and they give them high risk of biliary sludge. It's not contraindicated, but if you have other options like cefotaxime, better to use them. So it's not 100% contraindicated, but it's not preferred. Okay. Older children with a strep pneumo, Neisseria meningitis, Haemophilus influenzae, the antibiotic empiric choice is IV ceftriaxone. Sometimes you will add IV vancomycin. When is that? When you suspect there is a resistant strain of strep pneumo. And those all based on data from USA. Our strep pneumo in Saudi Arabia, it's highly sensitive to ceftriaxone. So if you start only ceftriaxone, it will be enough unless you have in your community the strep pneumo is resistant to ceftriaxone. So what's the duration of antibiotic? What do you think? All they have the same durations?
Depend on the causative agent.
Okay, depend on causative agent. Some they will clear earlier than others, and sometimes some of them need prolonged duration. So the shortest duration will go to, what do you think?
Neisseria?
Yes, Neisseria, it's usually 5 to 7 days. Then after that, Haemophilus influenzae, it's 7 to 10 days. After that, strep pneumo, it's usually 10 to 14 days. Then in specific immune, specific host like immune compromised patients or specific organisms, we have extended, more extended duration, like Staph aureus, at least 2 weeks, gram-negative organisms, at least 3 weeks. And with gram-negative, usually you need documented negative CSF culture. With the others, no need, but with the gram-negative bacilli, you need. And some cases with GPS, but not all. For group B streptococcal, it's 14 days. And salmonella in sickle cell, or even in immune competent, you will go to 1 month, 4 weeks. Okay. What is the complication of meningitis? Abscess formation, yes. Prior to abscess formation, patient they can have subdural effusion, and subdural effusion doesn't need surgical drainage unless the effusion size is large and causing signs of high intracranial pressure. Subdural effusion well known with Haemophilus influenzae and strep pneumo. Abscess formation, ventriculitis also can present, and abscess formation need surgical drainage. What else? We mentioned it with the pathogenesis.
Dissemination.
Dissemination. Dissemination to where? We mentioned it can cause abscess formation and cause ventriculitis. Hearing impairment. We mentioned it can reach to the nerve ending and cause damage to the auditory cells. So all patients with meningitis, they should have hearing assessments upon discharge or after discharge. Patients can have hydrocephalus too. The patients can have seizure. So those are the most common complications of meningitis. What is the role of dexamethasone with meningitis? So in adults, it's a well-known practice, as I know. And data in pediatrics, it's not well supportive of that. Still, the use of dexamethasone in pediatrics are controversial. The data showed it decreased mortality with the strep pneumo and decreased complications like hearing problem with Haemophilus influenzae. But the problem with dexamethasone that we need to give it with the first or before the first dose of antibiotic. And when the patients initially presented to you and you collect the CSF, sometimes you need time to grow the organism or to see the organism by gram stain. And for us as pediatrician, the first we need to save the patient. So we need to start antibiotic as soon as possible. So no times to wait for the organism identification. So still the use of dexamethasone in pediatric is controversial. I will mention the complication. It can also complicated by cerebral infarction. Some they have vasculitis too. So any questions regarding meningitis? Because gram-negative will known to cause mortalities and complication. So you need to base your duration with upon negative CSF culture. Not like the situation with Haemophilus influenzae, strep pneumo, and the others. So there's certain like conditions you need to repeat CSF. One is gram-negative meningitis. You need negative CSF culture to prove that you eradicate the organism. Two, if the patient is not responding to antibiotic. And so if the patient showed any signs of failure of antibiotic, you need to repeat your CSF cultures, and you need to send for extended sensitivity profile to see the sensitivity and your empiric coverage, if they match or not. Okay, and if there is like certain complications, like with the brain abscesses or with ventriculitis, you need a serial CSF cultures. Okay, let's move to encephalitis. So what is encephalitis? So we mentioned meningitis is the infection of meninges, specifically for the arachnoid meninges, and all the complication came after that. It will be disseminated to subarachnoid space and sometimes to the ventricular space. Encephalitis is the infection or inflammations of the brain tissue itself. So what is the pathophysiology of encephalitis? So it could be due to direct invasion of neuropathogenic organisms like herpes simplex virus, or due to slow viral replications like with HIV. And also there is another virus can present with like slow viral infection, like we mentioned it with the virology, if you remember measles. It can cause what we call it? Yeah, exactly. And it could be secondary to autoimmune. So you have infection you have infections like otherwhere, like in your body, and the autoimmune response will be triggered and cause encephalitis. So that's the usual pathogenesis, like how you got encephalitis. So it's the most common infectious etiology is viral, and most common viral etiology is for encephalitis is enteroviruses, but our focus usually in what? When you hear in herpes, so why is that? So the commonest is enterovirus, but our focus in herpes, why is that?
Because it can cause a CNS degenerative disease.
Okay, it can, like, we have bad mortality, and we have treatment. For enterovirus, usually it's self-limited and like not associated with high mortality rate. So the most common is enteroviruses. Also, influenza can cause encephalitis, herpes, especially herpes simplex virus, one, and other viruses like arboviruses. Bacteria can cause encephalitis, especially mycoplasma, and TB. Okay. So as you know, encephalitis can be caused by infectious and non-infectious etiology. And among the infectious etiology, like toxins, like drugs or whatever, all the presentation with encephalitis are similar. But the presence of fever help us to distinguish encephalitis from infectious etiology other than encephalopathy due to other causes. And sometimes the patient will have like a prodrome of illness like fever, headache, weakness, and that can go like for days. Usually the symptoms of encephalitis will start on week 2. So the patient will have lethargy. Some patients, they will have, and pediatric also common to have abnormal movement, seizure. Some patients, they will proceed to coma and death, unfortunately. So how to diagnose encephalitis? So as we see with CSF parameters, we mentioned the encephalitis can be, they can have normal glucose, they can have normal protein, but sometimes white blood cell will be elevated. Herpes simplex can be detected by PCR of the CSF, and also there is a role of neuroimaging. Sometimes for herpes, it's usually if the patient presented early in the course, they will have negative PCR. So if you have highly suspicious situation of herpes simplex, you need to repeat your CSF by day 3 or till day 7. In neuroimaging, like for herpes simplex virus, what you will see like with EEG or like with MRI will show you leptomeningeal enhancement in which like area of brain, like herpes simplex had like
Temporal. Temporal.
Temporal. So temporoparietal area, it's the most common like sites for herpes simplex infection. So EEG, if you run EEG in your patients, you will have like abnormal spikes in temporoparietal. MRI will show leptomeningeal enhancement. And in advanced situation, you will see, on CT, you will see some brain atrophy. So as I mentioned, sometimes if you have negative PCR, you need to repeat it day 3, like 3 to 7 days later from the first one. And this is in CT scan, showed like gross atrophy, and this is advanced stage, gross atrophy in the temporoparietal region. So we are interested on herpes simplex because we have treatment, and treatment need to be started as early as possible. If you have like high suspicion, start with high dose acyclovir, and if the PCR came as positive, you need to continue for 3 weeks, 21 days. Okay, and herpes also one of those situations you need to document negativity of CSF. Okay. Any questions regarding encephalitis? Any question? For this management only for herpes simplex, not viral. For influenza, we have oseltamivir. For other viruses, like it's like beyond your level. For bacteria mycoplasma, like you can start azithromycin or whatever. But for your level, like just I want you to focus on herpes simplex management, herpes simplex virus management. Okay. Okay, let's move to osteomyelitis. So what is osteomyelitis?
Infection of bone.
Infection of bone and bone marrow. So Why is that? Why we need to know it's infection of bone and bone marrow, especially in children?
Because it may lead to necrotic changes.
What do you mean by that?
يعني بيصير فيه اللي هو السكوسترم والفولكرم وممكن ما نلحق البون يصير فيه deformity permanent.
Okay, that situation with chronic osteomyelitis. So we have acute, subacute, and chronic. Subacute and chronic, if the symptoms present more than 2 weeks, and if symptoms less than 2 weeks, we are still in the area of acute. So why we need to know osteomyelitis is infection of bone and like in pediatric bone marrow, because most, like more than 99% of the cases, it's secondary to hematogenous source. So the infection will start in bone marrow, then separate to the bone. And the patients, if you did X-ray early on, if the patient presented less than 2 weeks, and you did X-ray, simple X-ray, it will be normal. You need to diagnose like osteomyelitis with MRI, because MRI will show you the bone marrow enhancement, the source, started from the nutrient arteries in the bone. But if you did, like the patient presented with symptoms of osteomyelitis, and you did your X-ray and you found those signs you told me about, the sequestrum or whatever signs of new bone formation, that means you are on chronic osteomyelitis. And the management is different regarding the duration. The causative organism usually the same. So in this patient, like you will see what? Is there anything in the picture can indicate this patient had osteomyelitis?
The signs of inflammation.
Okay, signs of inflammation, which is?
اللي هو warmth, redness, swelling, pain, loss of function.
Okay, so swelling and redness, as this patient had, it can present with osteomyelitis, it can present with cellulitis, it can present with fasciitis, abscess. All they can have these signs. Loss of function, you need like video pictures, or like you need to assess the patient by yourself. So this patient can have osteomyelitis and others, but what made me worried, like the patient held his arm in like fixed position, and it could be only for the picture, but like this is one of the signs you need to look for. If the patient held his like arm or whatever in fixed position, either with osteomyelitis or with septic arthritis. Also, the other signs distinguish osteomyelitis from others like cellulitis or whatever, the significant like buoyant bony tenderness. So in cellulitis, you will have diffuse pain. With osteomyelitis, the patient will like focus on one point. Okay, so we mentioned osteomyelitis, infection of bone and bone marrow, and in children, it's primarily secondary to hematogenous. Other causes can like present like trauma or surgery or infected contagious soft tissue, but it's like 100% secondary to hematogenous source of infection. So we chat a little bit about the pathogenesis. It's usually came from the nutrient artery. The organism enter the bone marrow from the nutrient artery and replicate till reach the metaphysis. And we have certain age group, it will stop here in the metaphysis because of the growth plate. But in patients less than 18 months of age, they will have still growing epiphyseal growth plate. And still growing, that means they have a rich vascular supply in this area. So the organism will travel through the growing epiphyseal growth plate till the epiphysis. And those age group, they will have in the epiphysis, you will have what?
Joints.
Joint space. So those age group, they will have septic arthritis with osteomyelitis. Okay. So we mentioned that already. So this is from your picture. They mentioned the same as the presence of epiphyseal growth plate can prevent the spread of infection to the joint, but in children less than 18 months, they will have still growing and they have a lot of vascular supply. So the infection can spread to the joint space. And this is the X-ray, showed what? Signs of what? So signs of newborn formation. So it's chronic osteomyelitis. So X-ray, it's like, we need to do it early just to distinguish, to see where we are in the illness. Also, we need to do it to rule out another like causes like trauma or whatever. But unfortunately, if you see signs of osteomyelitis in like X-ray, that means you passed your acute phase, you are in the chronic or subacute phase. So we mentioned the clinical manifestation, it's mainly fever, pain at the site of infection, patients, they will not use their affected extremity, and less like common complaint, the vomiting and others. What about the signs? You can see, as we mentioned, tenderness, focal swelling, warmth, erythema, sometimes in advanced stage, like you will see a draining fistula. And the presence of a draining fistula in osteomyelitis, it's an indication of surgery. So for now, for osteomyelitis and septic arthritis, the commonest organism is Staph aureus in all age group till proven otherwise. So in innate, you will have Staph aureus plus the neonatal organism, what we mentioned before, the GBS and the others. In school age group, it's Staph aureus plus the others. In sickle cell disease, it is Staph aureus plus Salmonella, but always Staph aureus. Skin soft tissue infection, always Staph aureus plus Strep biogen. Osteomyelitis, septic arthritis, it's always Staph aureus until proven otherwise. What is the common location? It's the large bone. In pediatric, like femur, humerus, and like then will come like tibia. Then you will have ulna and fibula and the others, but it's like the site of long large bone. Okay. So investigations, you will do the CBC, you will do differential to help you, but it's not specific. CRB and DSR. What about CRB and DSR?
They will be elevated.
They will be high unless it's chronic osteomyelitis. Chronic osteomyelitis, they will be almost near normal. It will be slightly elevated. What else? Like with acute osteomyelitis, the acute phase reactant, it will help us to determine the duration of antibiotics, like duration of IV, intravenous antibiotic, and would tell us like it will give us some hints about the patient's improvement. So if the ASR started to decrease and CRB is decreasing, so we mentioned that the patient is improving, and it's one of the criteria to shift from intravenous antibiotic to oral antibiotic. But in chronic osteomyelitis, it's not helpful to monitor ESR or CRB. Okay. Also in sickle cell, what do you think? In sickle cell disease, they will have high or low ESR.
High.
Usually in sickler, they will have low ESR because they don't have the ability, because the sickling, they don't have ability to have the sedimentation. So ESR will be low in sickler. So patients with sickler, as you know, they can have what a vaso-occlusive crisis, which can mimic osteomyelitis. And unfortunately, you cannot distinguish by ESR, like, is it vaso-occlusive or osteomyelitis? Synovial fluid, if you have like adjacent septic arthritis, you will take synovial fluid, you will aspirate because it's one of the surgical indication. If the patient had septic arthritis, you need prompt surgical intervention to prevent joint deformity. If you have the synovial fluid, so send it to culture. So previously they will run the synovial fluid analysis to see the white blood cells and glucoprotein. But the growing data showed it's not helpful to distinguish between the category. Only the helpful one is the culture. X-ray, we mentioned we need the X-ray to rule out another disease or to give us hints about the stage of the illness. Is it chronic or acute? Bone scan, it's not helpful anymore. MRI is more helpful and more with diagnostic value. It will show the bone marrow edema, but also with sickler, because they have vaso-occlusive crisis, they will have bone marrow edema. So the diagnosis of osteomyelitis and sickler is challenging. So what's the treatment of osteomyelitis? Antibiotic targeting which organism? What is the common
Staph.
So antibiotic targeting staph. And usually we will start with earlier, they thought we need the full course. The full course of antibiotic for osteomyelitis is can reach to 6 weeks, but usually it's 3 to 4 weeks. And initially we thought that we need to treat bone infection with IV the whole duration. But now the data came, the guidelines change for pediatric, and all the data came from adult population. And we started to apply it on pediatric population. So we shortened the duration of IV to maybe 5 to 7 days, depending on the patient's improvement, depending on the disappearance of fever, depending on the improvement of acute phase reactant. So if the patient by day 5, he's improving, we can switch from intravenous to oral antibiotic. Targeting staph, unless we have certain age group unvaccinated or less than 5 years with the risk of Kingi or patients with salmonella, with sickle cell, so we need to cover for salmonella, or neonate. For neonate, still we will do the whole course with IV. Okay. So we mentioned that. Chronic osteomyelitis, the duration is different. We can reach up to 6 months with antibiotic, but all with oral antibiotic. And surgery, as we mentioned, it's there is a certain surgical interventions in osteomyelitis if the patient fails to improve on antibiotic. So we need to do surgical drainage, and we need to send cultures from the drainage or from the bone to see if we have a resistant organism, if the patient have a fistula, if the patient have abscess, if the patient have septic arthritis. So it's all indication for surgical intervention. So this is only if you have a high risk of MRSA. So we need to cover MRSA, not only Staph aureus, the sensitive MSSA. So the causative organism we mentioned as before, it's Staph aureus, and the neonate Staph aureus plus the neonatal organism. Sickle cell, it's Staph aureus plus the others, plus salmonella. All age groups is Staph aureus, Staph aureus, Staph aureus. Then we have strep pneumo and strep pyogen can cause. So moving to septic arthritis. So we chatted a little bit about septic arthritis with osteomyelitis. So septic arthritis is infection in
joints,
in the joint space and joint capsule. And most commonly in pediatric, it's secondary to osteomyelitis. the source of septic arteritis. Secondary to hematogenous origin. Sometimes it can be secondary, as with stomatitis, secondary to trauma, secondary to wound, secondary to surgical intervention in the joint. And the causative organism almost the same, the lab is almost the same, the treatment the same, but the duration for septic arteritis is less. And the treatment for septic arteritis plus antibiotic, you need what to do? We mentioned
urgent arthrotomy.
surgical intervention. So surgical drainage is like prompt surgical drainage, not only surgical drainage urgent. So it's one of the situation you need to bother the surgeon to preserve the joint function. So we mentioned all that. So in clinical manifestation of septic arteritis, sometimes if the most common site is the hip. Sometimes in pediatric, it's difficult because it's the fatty area, so it's difficult to elicit all the signs of septic arteritis. But the commonest signs of septic arteritis, the patient will hold his, like if he had hip, they will hold the leg in flexed, abducted, and externally rotated position. And if the patient is, like above 1 year, or if the patient is walking, they will have like pseudo paralysis. And the mom will mention to you, like, why I'm changing the diaper, the patient's like crying a lot. So because she will move his, like she will move the joint while changing the diaper. So that's one of the signs you need to pay attention to. So like this table is almost the same as the previous table, so no need to bother yourself. Just the neonate, it's staph plus the neonatal organism. Children less than 5 years is staph plus a strep biogen or strep pneumo, or sometimes Haemophilus influenza in unvaccinated, or in certain age, like less than 5 years, Klebsiella kiengi is one of them. It's the same as osteomyelitis. Investigation almost the same, just management, it's immediate orthopedic consultation with appropriate anti-staph coverage. So we are at our last serious pediatric infection, which is orbital versus periorbital cellulitis. So for those two babies, can you like demonstrate the signs and symptoms for both, and which one you think he had just periorbital, and which one you think he had orbital? So what do you see in those pictures?
Swelling and redness.
Swelling, redness, okay, of? The eyelid?
The left picture, he can't open his eyes.
Yes, okay. So this is the all symptoms we can like, all signs we can see from the pictures. So swelling, redness of the eyelid, it can present in both orbital and periorbital cellulitis. Like fever, other signs of infection can present in both. But with periorbital cellulitis, the patient like looks happy. In orbital cellulitis, the patient looks very ill. This is one like way to distinguish between them. And in those pictures, like both they can have only periorbital cellulitis, but you can see this one, he might have orbital because like he looks ill, and the like you cannot tell, but there is like a little bit of proptosis. So proptosis is signs of orbital. Decreased visual acuity, you think it's with what? Periorbital or orbital?
Orbital.
With orbital, decreased visual acuity, and like painful eyelid movement with what? Or painful eye movement with?
the periorbital.
With orbital, not periorbital. So why we bother ourselves and distinguish between orbital and periorbital cellulitis? Because of what?
Management.
The management. So what do you think the difference is in the management?
ممكن في
maybe topical ولا IV يعني الادمنستريشن.
You are right. Okay, other than the administration of antibiotic. So with orbital, we need IV at least. With periorbital or like the other name of periorbital is preseptal, we can start with oral only. What else other than the antibiotic? Anyone like interested in OFTA? So orbital cellulitis, it's one of the emergency. So it's another situation you need to bother the surgeon. So needs prompt surgical evaluation to preserve the vision. And the complication with orbital is more like you can have more like intracranial extension with orbital cellulitis. That's why in some cases of orbital cellulitis also you need to cover for you need to add anaerobic coverage if you suspect intracranial extension. But with periorbital cellulitis, no. So just to understand like what is preseptal or where is preseptal and where is like septal or periorbital or orbital. So this is the orbital septums, and anything like anterior to that, it is preseptal or periorbital. Anything behind that, it's orbital. And we can understand the pathogenesis. It's the same as with like osteomyelitis and septic arthritis from the picture. So it can be secondary to hematogenous. So coming from the blood, the organism will come from blood supply. It can be secondary to like wound here or trauma or whatever in the skin soft tissue. It can be secondary to like adjacent sinus infection. Okay, clear? Okay. So we talk about the clinical manifestation. So fever can present in both. Erythema, tenderness, edema of eyelid can present in both, like butoproptosis, painful ocular movement, reduced visual acuity. It's only with orbital cellulitis. So the commonest etiologies, so it's the same as like the sinuses infection or whatever. So what they are, strep pneumo, group A strep, Moraxella, Haemophilus. With periorbital, sometimes the staph can cause also the infection. Orbital cellulitis, as I told you, sometimes anaerobes can have can be the causative organism. So for periorbital you can give antibiotic through oral or whatever, like if the patient's like ill in the beginning, you can start the course with IV, then finish it with oral, but usually it's outpatient management. For orbital cellulitis, you need urgent ophthalmological consultation to preserve the eye and prevent the complication, plus the IV antibiotic. And the choice of antibiotic is not like important, just remember the causative organism and what's the the outline of management. Okay, we are almost done. We have only like a ways how to prevent infections. So how to prevent infection? Usually implement infection control measures, washing hand, put the patient on standard precautions, like additional precautions like contact droplets airborne when it's needed. And when we need airborne, with which organism? We mention it in the viral.
TB.
Okay, TB, and with the viruses, we mention it in the lectures of viral, viral.
Measles.
Measles and?
Varicella.
And varicella, okay. And this is how you wash your hands. And the primary methods to prevent infections in children is through vaccination. Okay, so we are almost done. Anyone had any questions?